Hello, I'm George Amil. I'm presenting you a brief review about lower gastrointestinal bleeding and the most common causes and some lines of work to handle those patients. First of all, when we are facing with a lower GI bleeding, we want to try to identify the probable source, and in first line, can be provided by knowing the type of loss of blood. If there is hematochezia, which is the passage of bright red blood in the stools from the rectum, this may give us a hint that it may be a distal lesion, either in the distal small bowel or colonic lesion. However, if there is a great loss of blood from the upper GI tract, this may pass the GI tract fast and still come out as bright red blood. However, there is a lesser probability that this happens with hematochezia. On the other hand, if there is very dark stools, sometimes patients call it tar-colored stool or coffee ground stool. This usually suggests that the source of the bleeding comes from the upper GI tract and usually tends to come from either esophagus, stomach, or upper small bowel. Next, we pick up the history from the patient, and there are some hints that help us to make a correct diagnosis. We want to know how the bleeding started, whether it was gradual, intermittent, or whether it was continuous. Did the patient have a change in bowel habits, either constipation or diarrhea? This suggests that we're facing some chronic sort of lesion. If there is associated anal pain or itching, then this is an important sign that may suggest that we may be dealing with a very low source of bleeding from the rectum or anus. We want to know whether the patient has pre-existing conditions about his health, if there is liver disease or portal hypertension, because this might call for hemorrhage from the esophageal varices or gastric varices, if there is a coagulopathy, or if the patient already has been diagnosed with inflammatory bowel disease, which might then be the most likely cause for the bleeding. We need to check carefully whether the patient is already taking any sort of medication, and we know that some drugs are associated with increased risk of bleeding. Clearly, anticoagulants may cause bleeding from any part of the body, but clearly from the GI tract. Some anti-inflammatory drugs, namely the non-steroid anti-inflammatory drugs, are a common cause of gastric bleeding from many patients, or whether the patient is taking any antibiotics that may induce also some inflammation, some lesion, and cause some sort of bleeding, or whether there was a pre-existing infection that might actually be the source of bleeding. We want to know the family history of our patient. Although this is not clearly directly related, but if there is a family history of inflammatory bowel disease, polyps, or ulcers, this may also provide some clue about the possible origin of the current problems of our patient. Then we move to examine our patients, and there are some general signs that we always need to address and to evaluate in order to assess how severe the bleeding may have been. And the vital signs like the pulse, the blood pressure, the urine output give us a hint whether the patient has been severely depleted from volume in the blood, and therefore this might suggest a major loss of blood and a major bleeding. We want to look at the general appearance of our patient. Is the patient reasonably well? Has he had fever? Is he conscious and cooperative? Is there tachycardia? Are there any cardiac murmurs? The capillary refill time, is it normal? All this allows us to assess the severity of the problem that we are addressing. On specific examination of the abdomen, we need to check whether there is localized tenderness, whether the patient has splenomegaly, which might again suggest either varices or some hematologic disease. Is there hepatomegaly? Are there signs of collateral circulation in the abdomen, distension, ascites? All of these are signs that point to portal hypertension and possible cause of bleeding from varices. Then we need to look at the perianal region, and some patients may have evidence of fistula or abscesses or local tenderness, and this would suggest that we may be facing a case of inflammatory bowel disease, most likely Crohn's disease. Looking at the skin, is there pallor or jaundice? Is there any rash or evidence of arteriovenous malformations? We know that some vascular malformations go along either with skin or visible lesions, and these may also present in the gastrointestinal tract and be a source of recurrent bleeding. We have to be aware that some events may mimic GI bleeding, like some sorts of foods like candies, fruits, beets, laxatives, phenytoin, rifampicin. All of these may lead to change in the color of stools and may mimic blood. Therefore, if a patient has any of these pre-existing situations, we must reevaluate whether actually we are facing with the bleeding or not. As for black stools, the ingestion of bismuth, activated charcoal, iron salts, spinach, blueberry, or licorice may also give a very dark color to the stools, therefore mimic GI bleeding, which actually did not occur. After evaluating our patients, we have to keep in mind that common causes are more often the case rather than the rare causes. Therefore, we have to look for the most common causes first. If there is a lower bleeding and the patient has anal pain and constipation, then we really need to consider that the cause for this situation may be just an anal fissure. If there are small amounts of blood, mostly on the toilet paper, not mixed directly with the stools, again, these are signs that suggest anal fissure rather than any other lesion. Some patients have bleeding from Meckel's diverticulum, and usually this happens as a sudden hemorrhage in a patient that has been otherwise well until that particular moment. There is no apparent disease, and there may be severe bleeding and a marked drop in hemoglobin. Therefore, in this case, we really should consider Meckel's diverticulum as a possible diagnosis. For polyps, sometimes we have intermittent loss of blood, and usually the amount of blood loss is small, and again, these patients do not have any other signs or pain, and endoscopic examination will confirm this diagnosis. And there is a particular group of patients, usually small infants in the first 3 or 4 months of life, who are otherwise very well, sometimes even breastfed, and their stools suddenly start to have streaks of blood. And these cases most commonly are due to proctitis, and this may be caused by food allergy, usually to milk, cow's milk protein allergy. And in this case, even if the baby is breastfed, we may consider this diagnosis and just asking the mother to avoid dairy products in her own diet or switching the formula into an extensive hydrolysate formula may give us a sudden improvement in the condition, and therefore these babies may not need any further investigation. Usually this is a self-limited condition. If there is a sudden change in the consistency of stools with acute diarrhea, even if blood is being passed, we of course need to consider infection by invasive bacteria like Salmonella, Shigella, E. coli, Clostridium, and there is a specific context of these cases, and usually diagnosis is straightforward. Then we may we need to evaluate other signs and other tests to identify the source of the condition. And we always must look at the growth charts of our patients, because if there was some loss of weight in the last few months or some growth retardation, again we need to consider chronic condition, and inflammatory bowel disease, specifically Crohn's disease, has to come to mind in this context. Of course, there are other conditions, but associated with loss of blood, of course, Crohn's must come in the first line of diagnosis. If there are signs of systemic inflammation, and this may be derived by evaluating the blood count, the erythrocyte sedimentation rate, the C-reactive protein, and the count of platelets, all of these suggest an ongoing inflammatory process, again suggesting a possible diagnosis of Crohn's disease. We can look at the calprotectin or lactoferrin in the stools. These are proteins derived from the neutrophils, and they are usually increased in the stools of patients with intestinal inflammation. However, we must keep in mind that other sources of calprotectin may show up in the stools in patients with polyps. Therefore, a very high value of calprotectin in the stools in an otherwise healthy patient with just some blood occasionally in the stools may suggest a possible diagnosis of polyp. Usually, endoscopy is not an emergency procedure in patients with lower gastrointestinal bleeding. After having this baseline investigation in our patient, we may need some specialized tests, and the technetium scan is useful to diagnose Meckel's diverticulum. However, a negative result cannot exclude completely the diagnosis of Meckel's. We may need to follow these patients and perhaps use alternative methods like the capsule endoscopy or even colonoscopy, and if positive for source of blood from the terminal ileum, then discuss the situation with our colleague surgeons. We may also use wireless capsule endoscopy. Usually this is not an emergency procedure, but it can be in facilities that have the capacity, can be arranged fairly soon, and it is quite useful for small bowel lesions because it may identify the source of bleeding. But if we consider a possible diagnosis of Crohn's disease, we have to consider if the patient may have signs of some long-standing disease, may have stenosis, therefore there may be a risk of retention if Crohn's disease is suspected. Therefore, in our own experience, when we feel the patient may have Crohn's disease, usually we do a patency capsule first before doing the real wireless capsule. And if the previous investigations are not informative, then colonoscopy may be done both for diagnosis and sometimes for therapeutic purposes. Of course, inflammatory bowel disease is increasing in the pediatric population. It may present as lower GI bleeding, therefore we always have to keep in mind this diagnosis as a possibility in more patients. Usually they come with a progressive disease, so in most cases there has been some previous signs of disease before the actual bleeding occurred. However, this may not happen in all patients. There may be general or extraintestinal signs and symptoms like loss of appetite, loss of weight, fever, arthritis, recurrent after or erythema nodosum. All of these point to a diagnosis of possible inflammatory bowel disease, as well as recurrent abdominal pain or recurrent diarrhea with loose stools. And usually this also comes along with some biochemical markers like the stool calprotectin that I mentioned before. Again, I remind you that polyps may also give false positive values of calprotectin, and the markers of inflammation that we can see from the complete blood count like the ESR, CRP, or thrombocytosis. And if IBD is suspected, then the diagnosis relies on full colonoscopy with ileoscopy and biopsies from all segments of the lower GI tract. Another group of patients that commonly present with lower GI bleeding are patients with polyps. There are polyps that cause bleeding and other polyps that usually do not show up with bleeding but belong to a special group, as we'll see in a minute. Most bleeding polyps are usually inflammatory. Usually histology confirms they are juvenile polyps, quite often isolated, and usually in the left colon and sigmoid or lower rectum. In the absence of family history of cancer or polypoid syndrome, then juvenile polyps are the most likely cause. There is no premalignancy potential, so we can reassure the families. However, these patients must be treated in order to remove the polyps. Full colonoscopy is therefore recommended. There may be multiple polyps, and histology must be evaluated in all of them because there may be a chance that some of them are slightly different from the others, and the symptoms may persist if not all polyps are actually removed. And although most of the polyps lie in the left colon, once the full colon has been prepared for colonoscopy, why not check the whole colon and then reassure the patient and the family that we did not leave any other lesions in the colon. Therefore, full colonoscopy is usually recommended even in the juvenile polyps in the lower colon. If there is a family history of polypoid syndrome, then elective colonoscopy is performed even in the absence of bleeding for diagnosis, and these patients rarely present with bleeding. We can also look for additional imaging of the small bowel. If there is persistent or occult lower bleeding, then wireless capsule may be quite useful to identify the source and the number of these lesions, although in centers where facilities are available and expertise, a double single balloon enteroscopy may also be used, and this may have the advantage of being both diagnostic and therapeutic if appropriate. I would like now to share with you some images of polyps in the colon, and we can see in the right image that clearly there are signs of recent bleeding in this case. Here we see patterns that are consistent with ulcerative colitis, and this is a diagnosis again that relies both on endoscopy but also on histology. Therefore, multiple biopsies are always recommended. In this case, we see the exam of a wireless capsule in a patient that had persistent chronic bleeding without any other obvious cause, and actually the software shows and helps to localize the moment where blood was obviously seen in the small bowel. Therefore, if we cannot control the situation by medical means, then we may refer our patient to the surgeons. And in fact, this patient turned out to have diaphragm disease with various areas of stenosis in a short segment of the small bowel and sources of bleeding. We see a rare malformation from the blood vessels. It's called blue rubber bleb syndrome, and these patients have vascular malformations of the venous tissue. Therefore, they may have several lesions that may occur anywhere in the body. They may be intramuscular, subcutaneous, or and usually those may cause some pain when they swell and cause discomfort to the patient, but usually are self-contained. However, when these occur in the GI tract, they may be a source of continuous bleeding, and actually this patient had multiple transfusions and required long-term treatment. At some point, he was operated. He had more than 20 resections of lesions in the small bowel. He was well for a number of years, but then he started to bleed again, and this endoscopy capsule showed that the lesions had recurred. and had to be addressed, at least some of them, through double balloon enteroscopy in order to resect or inject the larger lesions. In this image, we see a polypoid syndrome. This is a family polyposis. This, as you can see, these polyps are sessile, very small. They do not bleed. However, they need to be formally diagnosed and investigated, and these patients have some oncogenic potential. Therefore, they need a long-term follow-up and sometimes elective colectomy. Well, if there is a bleeding lesion, we may need to address it through endoscopy, and usually we can use either injection of the lesion, and for this we may use epinephrine locally, or we can use hemoclips. Of course, that hemoclips are more efficient in controlling in the long run, because epinephrine goes away and the source of bleeding may restart again. Therefore, epinephrine may be useful to stop immediately the bleeding, but there may be recurrence. Therefore, if possible, hemoclips are preferred. If there are polyps, usually they are removed with a snare electrocautery. For larger lesions, however, special technique may be required because some polyps may be quite big, and therefore segmental resection may be recommended and preferable for the safety of the patient. If the polyps have a very large stalk or are sessile, then some care must be taken in order to avoid perforation. In this case, submucosal injection is recommended with saline, sometimes with added epinephrine, in order to raise the lesion and reduce the risk of perforation of the colonic wall. Small polyps then may be removed with just the biopsy forceps. We see here a source of open bleeding, and again here, and this may be addressed, as I mentioned, with hemoclips, and multiple clips may be required, or through injector, and then control, at least temporarily, the situation until hemoclips can be placed in the patient. We see here an image of various clips applied to a bleeding lesion, and that managed to control it.